now let's talk about our endoscopic journey in Nepal. And this presentation, I designed it for uh, beginners who would like to aspire for endoscopic spine surgery, and people who are already performing microscopic or open spine discectomies and fusions or decompression surgeries. So already uh, Dr. gave my introduction there. So we'll be talking briefly about indications, contraindications, how to select patients, and how to investigate or image them, and as a beginner surgeons, what are the challenges that we might face regarding starting endoscopic operations at our centers, and some pearls and pitfalls. So the philosophy of endoscopic spine surgery is uh, it's it's because of the illumination that it gives, and the SD high definition video image that gives the clarity to what we see uh, is different from in microscopic or open surgeries. And endoscopic surgery, it is a water based surgery, so there is already in the cavity there is some water pressure. Usually it is kept above 40 millimeter of mercury, up to 80 or 100 millimeter also. So this kind of hydrostatic pressure is maintained inside the endoscopic cavity that we create for the surgery. And the pressure, this helps to stop any venous bleeding. If there is blood oozing from the bones also is reduced very much. And this gives us the pretty much clarity during surgery, and it helps to visualize neural structures clearly. So in microscopic or open surgeries, one of the most difficult part in discectomies or fusion surgeries or decompression surgeries, the blood epidural bleeding is tremendous, and some beginner surgeons might find difficulty in controlling the epidural bleeding, which might lead to increased surgical time and blood loss also. So in an endoscopic spine surgery, blood loss is pretty much less. The hydrostatic pressure helps in hemostasis, and the hydrostatic pressure also retracts the dura and the nerve root slightly. That allows us to reach anterior to the dura, visualizing the disc in a pretty much better way. The illumination and the visual point in microsurgery or open surgery is outside the body of the patient. So the bony structures and the soft tissue, it hinders the proper visualization inside the surgical or cavity or the spinal canal itself. But however, in the endoscopic spine surgery, the endoscopy is put pretty much closer to the dural structures beneath or at the side of the bone. So the visualization angle is wider, and it's much clearer due to the um, proximity of the endoscopic camera to the neural structures. The advantages of unilateral biportal endoscopy basically is it is very much similar to microsurgery in many aspects. The endoscope in microsurgery, the visualization point or the camera is outside the body. However, in the endoscopic surgery is closer to the surgical cavity or the area of interest. So endoscope, the visual point or the orientation of the surgeon is a little bit difficult, or a little bit newer to us. However, with some practice and with some experience, the visual field and the anatomy gets acquainted to the surgeon pretty quickly. the surgical instruments that we can use in unilateral biportal endoscopy is similar to the original or the our traditional equipments that we use during our in open microsurgical procedures. The disc forceps, Carician rongers, dissectors, nerve retractors. These are pretty much similar to microsurgical instruments. So the surgery becomes familiar to us, and in theaters also we don't need much instruments to begin with. It's cleaner and safer because of the hemostasis that is provided by the hydrostatic pressure. It has got wider visualization angle, and of course it has got smaller incision, and the minimal soft tissue and bone damage. The soft tissue damage due to in open surgeries or microsurgery is little bit higher because the muscles need to be retracted laterally in a laterally in laterally a little bit more than what we do in endoscopic surgeries. In endoscopic surgeries, the incision is just like 0.5 to 1 millimeter, 1 centimeter in length, and the muscles are dilated, not retracted. So the muscles get preserved and the bony dissection that we need to do in microscopic surgeries is pretty large. However, in endoscopic surgeries, smaller bony work can give a larger intradural or the thecal sac visualization, spinal canal visualization, and that helps to build up a true minimal invasive spine surgery.
Recording in progress.
So the indications of endoscopic surgeries are pretty much similar to open or microscopic discectomy surgeries. I won't be going much into deep, but these are some indications among the herniated disc, all sort of herniated disc like central, paracentral, lateral, foraminal, extra foraminal. These can be dealt with endoscopic surgeries. Lumbar spinal stenosis is another modality or more disease that we can handle in a efficient way. From one side, we can dissect the or decompress the opposite side also, and either it's a lateral stenosis or central canal or a combination of all these, hypertrophic ligamentum flavum or ossified ligaments, foraminal stenosis due to facet joint hypertrophy or ligament hypertrophy. These all can be dealt with unilateral biportal endoscopic surgery. And among other indications, the spondylolisthesis is also a indication. For beginners, it might be a little bit difficult because of adhesions and the different anatomical structures. But after progressing or doing some being familiar with the anatomy, spondylolisthesis can also be dealt efficiently. And in if there is instability during the in listhesis, it also can be dealt with endoscopic uh, T-leaf procedures followed by fusions. And other indications, pyogenic discitis is a very good indication for endoscopic surgeries because of continuous irrigation and proper visualization of the neural structures. There we can do a thorough washing or and debridement of the pyogenic or granulation tissue, and if needed, we can add on the debridement procedure with decompression and fusions also. So epidural abscesses can be dealt with uh, endoscopic surgeries. The continuous irrigation, it helps a lot, and it helps a lot to clear out the infected tissue and decrease the bacterial load. Revision surgeries, these are in revision surgeries. However, what I like to add is revision cases, there is a lot of adhesions and the anatomy is different, so maybe it's not for the beginners, but after some experience and with the later on the learning curve, revision surgeries, these can be efficiently and effectively dealt with endoscopic surgeries. So there are some contraindications. High grade spondylolisthesis, if there is grade 3 or grade 4, the chronic listhesis cases, the anatomy is slightly different. There is a lot of dural or the epidural adhesions, fibrosis going on, and it makes the endoscopic surgery difficult and a little bit cumbersome. So maybe I should put this in um, relative contraindication, because a lot of experts these days are dealing majority of spondylolisthesis also with endoscopic surgeries, and especially intradural tumors or intramedullary tumors. Still now, the endoscopic operations are pretty much in development and not much popular, uh, especially because of the hydrostatic pressure that we need to create inside the surgical cavity that hinders the treatment of intradural and intermedullary tumors by endoscopic approach. Stenosis caused by uncontrolled infection, especially tubercular infections in our part of the country or our part of the world. If there is uncontrolled infection involving paraspinal tissue and other things, there might not be a good tissue plane to work on, and the hydrostatic or the water pressure that it might leak into the paraspinal or the anteriorly to the retroperitoneal tissue, which might cause problems. So this is also an contraindication to um, endoscopic approach. So complications, we all know these are similar complications. If we consider endoscopic surgeries, there are some peculiar complications related to the water pressure. If it is too high or if it is not maintained properly, it might cause intracranial problems, including raised intracranial pressure, sometimes hematomas, and post-operative headaches also. However, if the pressure is maintained in a proper way, below up to 40 to 60 millimeter of water or mercury, it might not, it usually does not cause any central or intracranial problems. Other peculiar problems that we might face is water leakage into the retroperitoneal tissue or the swelling into the operative area, especially in the buttock, and post-operative leakage of fluid or uh, the water from the wound, which might be seen up to 48 hours also. And placing a drain in the site, of course, it helps. There are other complications which we are all familiar with. Discectomy procedures or or decompression procedures, these are all common to our open or microscopic surgeries. So begin how if we decide to begin transition our practice from microscopic or open surgeries to an endoscopic surgery, so these are few problems that we might face. So as a beginner, what we face is there is limited access to quality UB training opportunity in the vicinity, especially in our part of the country or our part of the world. The training opportunities are relatively rare, and we need to move to India or China to get out of the country, out of from our place, leaving our busy practice and going somewhere else to be get trained and acquainted to the UB or endoscopic techniques. So learning curve is another problem. It's quite steep, and in the beginning it might take a little bit of time. So operative time initially it might get larger or longer, especially if you are a busy surgeon working in a high flow center where you need to cater a lot of patients. These starting a UB surgery or endoscopic surgery, it might take a little bit of effort in the beginning, because the surgical time it's usually for my first case it was like 4.5 hours for a simple left-sided L4 L5 discectomy. However, I was performing open or microscopic surgeries for last 10 years, but to begin with my endoscopic operation, the first operation, it took me almost like 4.5 hours, but at the end of the surgery I was happy. And with subsequent surgeries, the operative time it decreased, and now simple one level discectomy, either it's a left sided or right sided, I tend to complete below 1 hour. So at the end of the at the end of um, the training or the learning curve, the surgical time is not much of problem. So but for the beginners it might get a little bit cumbersome to start with. So high stress levels and long surgical time during initial cases is little bit problem, especially in high flow centers. And sometimes we feel a peer pressure and suboptimal support from the departments that we or the colleagues that we work with, especially the anesthesia team and the operative staff, operating theater team. We need a good support from anesthesia, not only anesthesia support, but also from our scrub nurses and the CM technicians, and definitely from the patients that we believe on us and let us perform these new interventions in their bodies. So initially we might face these problems. Other problem that I faced during my initial pro days was arranging for the equipments and buying or purchasing those equipments. So endoscopic operations or endoscopic surgical equipment, if we consider it in totality, it is a little bit expensive in our country. The endoscopic setup for unilateral biportal endoscopy that I bought in my center, it cost me like around nearly about 70 to 80,000 US dollars. So for a developing country like us, it was a little bit difficult. And another thing is, if you consider unilateral or biportal endoscopy, the equipments required or the equipment needed for uniportal endoscopic, this is much higher than biportal endoscopic equipments. In biportal equipments, we can incorporate our open surgical or microsurgical equipments inside in the practice also. So uh, limited and so how does a beginner start? So if you plan to start by endoscopic surgeries at our center, the first thing is we need to be determined to do it. So initially we might face problems, but at the end of a year or 6 months of your practice, you will be happy. Your patients will be happy, and the surgical time will also decrease. Now I feel that for doing a discectomy in a microscopic way, it is much easier. Um, Endoscopic way is much easier and faster than microscopic in discectomy also. And in the beginning we need to be very cautious about our patient selection. We need to, what I did in my few first cases was I um, I frankly counseled my patients about endoscopic surgeries and asked, let them know that if the surgery is difficult or it's if I can't complete this by endoscopic approach, I would possibly convert it into microscopic or uh, microscopic or open surgical approach. So in that way, I was open to my patient, and initial cases I was more confident in the theater. However, I didn't need to convert any cases, my personal cases, to open surgeries. I completed anyway. The first case, it took me for about 4.5 hours, but subsequent cases the time was decreased. So in the beginning, I suggest our junior colleagues and residents to select straightforward cases. So what are the straightforward cases? Like patients with isolated single level pathology without significant instability or deformity. So if there is a I suggest if there is a left-sided L4-5 disc, it would be the first ideal case to start with. Simple paracentral or lateral recess disc protrusion, disc herniation would be a very easy case to start with. So in the beginning, little bit complex cases like multi-level stenosis or ligament hypertrophies and facet hypertrophies, these sort of cases, it's better to postpone these cases to later on and start with simple discectomies and easier cases in the beginning. Right, operating for a right-sided surgeon, operating from left side is much easier in biportal endoscopy, because the scope side is already always on the cranial side, and the working side is on the caudal side. Working hand is on the caudal side. So if you are holding the scope from your if it is a left sided pathology, you will be holding your scope with your left hand, and you will be operating with your dominant right hand, so it becomes much easier. So for right-handed surgeons, left-sided approach, left-sided pathologies are much easier than right-sided pathologies. Proper patient positioning and equipment setup of the equipment is utmost important. And as I earlier said, we must have a plan B. Like if you in the beginning, if we can't complete our cases, we need to have a plan B to complete the case with microscopic or open spine surgery. So we need to counsel our patients regarding this. Even today, also, um, if I'm going to do a complex decompression case or a para UV, at that time, or fusion TLIF, endoscopic TLIF, I always take consent to convert my surgery to open surgery anytime I feel comfortable or feel uncomfortable during the surgery. So avoid overestimation of our own capabilities, and underestimation of complexity of certain cases. This is one of the important issue that I would like to discuss, because in the beginning, if we are very enthusiastic about the procedures, endoscopic procedures, and sometimes we feel peer pressure uh, 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 about proving ourselves on these new techniques, we might overestimate our own capabilities, and sometimes we might underestimate the complexity of certain cases. In these scenarios, what we need to do is working in a team, and having some seniors and junior colleagues along with us helps a lot. Boosting each other confidence, uh, repeatedly seeing our imaging or intraoperative help, taking help from intraoperative images, and clearly uh, studying the MRI and other CT scans before the surgery, and having a good plan of course, always helps. Seeking advice from experienced colleagues and mentors can mitigate all sort of these risks. In initial cases, you can always discuss your MRIs and patients um, clinical findings with your colleagues and your seniors, mentors inside the country, inside your department, outside the country, and everywhere. The world is global like these days. So my message is start with easy case. Paracentral soft L5S1 or L4 L5 disc is ideal case to start with. It preferably in a left side for a right-sided surgeon, right-handed surgeon, and right side for a left-handed surgeon. So migrated discs, maybe second cases, simple decompression can be started after you complete or you are confident with the anatomy and familiar with anatomy in the beginning. So challenging clinical scenarios, large paracentral disc, central disc, large huge central disc, upward or downward migrated foraminal or far lateral disc herniations are little bit cumbersome and difficult, but with practice this must come into your easy zone or comfort area. Large facet shoots also should not be treated by a beginner. Dural adhesions are common, and dural and nerve root sleeve injuries should be expected during our surgeries. Dural adhesions, especially in revision cases or chronic low back pain cases where the pathology has been there for a long time, and these days a lot of epidural injections and epiduroscopy and other interventions are being performed by our pain physicians and colleagues. This might lead to unnecessary or epidural fibrosis, tissue adhesions, and these sort of cases that we should be cautious and try to prevent dural or nerve root sleeve injuries during our operations. Calcified disc herniations are also potentially difficult to remove and often require power instruments, drills, and chisels to be used during the surgery. So these are some challenging cases that you need to be cautious and be not start with in the beginning. So patient education for the surgery is very much important. How much we highlight on this topic or this part of the presentation, it's always less, because a comfortable patient and a patient that has understood his pathology or the problem is always a good patient, and it's better to have them in our confidence. We need to educate the patients about our procedure, what we are going to do, how is it different from what we used to do, and what are the shortcomings or the problems of the procedure, and when would we want to change or convert our endoscopic operations if we can't, just in case, complete the operation endoscopically to open or a microscopic surgery. So these sort of things we need to discuss with the patient so that they have a realistic expectation about the operations and the outcome of the surgeries. So discussing potential risk and benefits of these things, and of course about the possibility of conversion to open or other form of our surgery. So to conclude with, I would like to thing is, you understand the pathology first yourselves. The neurogenic pain or neurogenic claudication pathophysiology should be understood to dissect out the symptoms of patients that present to us. The patient, if we see a MRI image, we might just see a disc herniation or a canal stenosis, but the patient does not come with this. The patient come with back pain, neurological deficit, weakness, numbness in the limbs, buttocks, or um, uh, there there could be facet joint problems, sacroiliac joint problems, other pathologies also. So understanding the patient and correlating these findings, clinical findings, with proper imaging of MRI or CT scan is always important, and we need to be precise about the pain generators or discuss pain generators of back pain and correlate this finding with clinical findings and radiological imagings, and derive a proper plan in our mind for a proper management of the patient. The endoscope, either it's an endoscopic discectomy or open surgical procedure, it's just a part of the management. It's not the holistic management plan. The patient, if he has multiple joint problems, other things, we need to address those along with these procedures, and employ a staged management. In that way, if we are clear about the pathology going on, we are able to dissect out the symptoms and correlate with the identify the pain generators of the patient, then we can employ a staged management protocol by opting for the least invasive treatment first. Provide them with rest, um, medications, injections. There are a lot of epidural injections or other short forms of injections that are being used in the spine, and ultimately there are surgeries, um, open surgeries, endoscopic surgeries, or fusions, and we need to choose according to our patients and their symptoms. So, and I would like to highlight that the whole goal of endoscopic surgery is to reduce the amount of fusion by reducing uh, soft tissue damage, as well as, and more importantly, the bony dissection, that is that bony work that we do with open surgeries or microscopic surgeries. So always try to avoid, wherever there is it is possible, avoid fusion, and unless there is a gross instability or deformity for a degenerative pathology, it's not advisable these days. So, and to discuss further in this presentation, initially I prepared this presentation for in with regards to the beginners, but Dr. Kamil, this he added few questions to this, and I would like to bring this into a discussion. And thanks for him. And I like to have your inputs in this also after I finish. Um, First thing is transforaminal versus interlaminar endoscopy. So personally, I don't perform, or I haven't performed transforaminal endoscopic surgery. I was trained in biportal endoscopy, and that's my field of work. But to my knowledge, I have colleagues who work with transforaminal surgeries, and they have also shifted now to interlaminar endoscopy. Transforaminal surgery, the indication for now, I think is a far lateral or extraforaminal disc, which can be easily taken out from outside the foramen. I think that's a good indication. But however, with the paracentral or central disc herniations, transforaminal discectomy, these days more and more people are not performing transforaminal endoscopy, and they are coming to interlaminar endoscopy itself. So indications have decreased, but still transforaminal endoscopy, the scope is there, and there might be few selected patients that you can operate with transforaminal endoscopy. Choose transforaminal endoscopy over interlaminar approach. So that is one thing. And for transforaminal endoscopy, what I believe is the foraminal area is very narrow. nerve root is already in stressed out or tensed. So in that condition, introducing a scope inside the foramen and operating from there is a little bit cumbersome, or it might be difficult for many surgeons. And it has been shown that with transforaminal endoscopy, the rate of paresthesia, post-operative paresthesia, neuropraxia, or nerve root damage is higher than with interlaminar endoscopy. So, considering discussing about monoportal or biportal endoscopy, initially I trained myself in monoportal endoscopy, but with time I find that biportal endoscopy is much versatile, and the bone work that we need to do with biportal endoscopy is much less than with monoportal endoscopy, and especially for the cases like global stenosis, where we need to operate from the opposite side to the opposite side. From the ipsilateral side, this sort of cases, biportal endoscopy is more versatile in this regard. And the I think the benefit of monoportal endoscopy is, if it is a simple central disc herniation like L5S1 or L45, if there is pretty much less bone work to do, I think monoportal endoscopy is easier to operate than biportal endoscopy. And the learning curve is also, I think, it's a little bit shorter with monoportal endoscopy than biportal endoscopy. The triangulation part initially that we need to do for biportal endoscopy, and begin to coordinate our both hands to put the vision inside the operating area, is a little bit difficult in initial few cases, especially for the beginners. And after when we are operating on the opposite side, like if I am a right-sided surgeon and we need to operate from the left side, we need to train our left hand for working using Carison rongers or disc forceps or dissection instruments. So it might be little bit difficult for beginners. So in that regard, biportal endoscopy has a little bit upper hand. But however, what I feel right now at my career is I prefer biportal endoscopy over monoportal for majority of pathologies. So drain or no drain, it usually depends. Sometimes if the surgery is large, some surgery is lengthier surgery, and lot of if there is lot of uh, water collection in the buttocks or the operative area post-operatively, I put drain. But however, these days usually I don't put drain for simple discectomies or decompression surgeries. So ligamentum flavum, it's a friend or a foe. So basically, in microscopic surgeries also, we tend to preserve the ligamentum flavum as far as possible. And in microscopic surgeries also, we can in endoscopic surgeries also, ligamentum flavum dissection it's usually I prefer to do it at the last, and take out the ligamentum flavum in total, unless if it is a simple or a paracentral disc which is just above. If it is L5S1 and I don't need to do a much bone work, it's just above the ligamentum flavum, and if I can do it with just a phlebectomy, little phlebectomy, then I prefer to not to take I prefer to take the ligamentum flavum first in piecemeal with a arthroscopic punch. So if you are familiar with the arthroscopic punch, it has anteriorly protective area, and it cuts from the center, and with that instrument I haven't have any dural tears or any problems with that. And once we have caused a small rent in the ligamentum flavum, the water pressure that water enters inside the spinal canal, and it retracts the dura away from the uh, ligamentum flavum, and that helps us in easier or smooth dissection. So unless it's uh, a simple central or paracentral disc which just lies above the ligamentum flavum. I usually protect the ligamentum flavum, first do the complete the bony work, remove the lamina and the medial edge of the facet joints as far as possible, and then take out the ligamentum flavum in total, or dissect it out in later part of my operation. So position lateral or prone or lateral. Recently, these days, many surgeons are performing surgeries in lateral position also. But being a neurosurgeon, I'm familiar. I used to perform microdiscectomies and open spine surgeries in prone position. So I feel comfortable with prone position itself, and I haven't had a need for lateral position surgeries. But especially for if there is a morbidly obese patient where prone surgery would be difficult in that cases, or a pregnant lady who is on the later half of the second trimester or third trimester itself. In that cases, if we need to do discectomies, lateral position surgery would be preferable. However, I'm sorry, I don't have much experience on lateral position. So coagulation and ablation mode of surgery, but it's just like cutting or coagulation mode of our regular uh, regular cautery machine. So in a radio frequency or radio frequency plasma generator, coagulation mode is always there, and it's the similar kind of mode. It coagulates the tissues, shrinks the paraspinal. It is used to shrink the paraspinal tissue or any coagulate any bleeding vessels or epidural tissues that we see. And in coagulation mode, this is pretty much different than the coagulation or cutting mode. So it basically cuts away or the burns away the tissue, but the tissue burning is not because of heat, but it's because of electrolytes or S plus ion that it dissociates from the tissue and evaporates the tissue itself. So coagulation mode and coagulation mode, these are two modes that we find with our radio frequency plasma generator machines, and these are the basis of our endoscopic surgeries. Regular cautery machines, because of the water medium surgery, we can't use in our endoscopic surgeries. So these are the ones that we use for our endoscopic operations. So maybe I'm taking a lot of much time, and I think it's time we need to discuss some few more things and answer questions from our juniors. And if there is anything that our professors, our seniors can add on and discuss, I'm very happy to answer or discuss further. Thank you.
Oh,
This
sir.
yes, this beautiful picture on my side is the Kathmandu famous Patan Darbar Square. These are old traditional buildings, and it's one of the unique UNICEF World Heritage Site in Kathmandu itself. So thank you.
Thank you very much, sir, for
Sorry, Dr.
yeah.
Suresh, we cannot see any picture of Kathmandu. I think you have stopped your screen sharing. So
No, this is the main temple is probably what was sir talking about.
I thought Dr. Suresh showed us a picture, but I couldn't see.
Sir, thank you very much for your brilliant presentation. it's actually very important for all of us as young neurosurgeons to know deeply about, be interested deeply about this subject. And also, I would like to tell that the thing that you pointed regarding the overestimation and underestimation is also most important for young neurosurgeons, because we all have fear and insecurity in front of possible complications which can happen. So for us, it was very important. As a moderator, I would like to ask the first question. Regarding the endoscopic surgery, what is your opinion about age preferences? How would you go for the young generation or for elder generation? So, for example, one level disc herniation, the patient 25 years old or suppose 30 years old. So you will definitely all the time will go by endoscopic, or you will still have some doubt regarding the open surgeries. Because as far as I know, while doing my residency in Russia, I had a couple of neurosurgeons who were preferring young generation directly for endoscopic procedure.
Yeah, yes. For these days, for younger patients or middle-aged patients, I almost always perform endoscopic operations for discectomies or decompression surgeries. Like if there is a central canal stenosis or foraminal stenosis, I do deal it with unilateral biportal endoscopy. And if there is a patient, like if he's in late 70s or 80s with cardiac comorbidities and respiratory problems, the fluid intake, the medium surgery, it might get accumulated, and there might be a little bit increased anesthesia intraoperative risk, anesthesia risk with of fluid overload. Another thing is the time duration. Most important factor is the time duration of surgery itself. It could be higher in beginner hands. So for endoscopic surgeries, uh, I prefer younger patients and avoid older patients. Still now practice, but with evolution of my experience, I think in any age patients we can perform endoscopic operations. It's safe, and a lot of experts that my mentors also, they perform endoscopic surgeries in at any age, like 75, 80, with comorbidities in those patients also. And the benefit of endoscopic surgery is if we can perform it in a pretty less time, if the time duration of our surgery is reduced, we are quick enough without procedures, we can perform this kind of surgeries in epidural anesthesia without having the patient intubated, partially sedated. In that case, this sort of surgeries are beneficial.
Okay, thank you. And also one more question regarding the patient with osteoporosis.
Correct.
So do you have some particular steps about that? If patient has osteoporosis, so will you go for endoscopic or open?
I don't think.
Can you stop your screen sharing, Suresh, please? We can see each other bigger in the.
Okay, sure.
Thank you so much.
Okay. So I don't think osteoporosis should be a problem operating on endoscopically, especially because the philosophy of endoscopic surgery is to have a minimal soft tissue damage, especially minimal soft tissue damage, as well as minimal bone work that we can achieve same endpoint of the surgery with less bone work. So I don't think osteoporosis should be a contraindication or any problem for endoscopic operation.
Thank you, sir. We have few questions from our chat. Let me just read them.
These are not questions.
These are not questions. Okay. Anybody has from the audience questions, please put to the, yes, sir.
Thank you very much, Dr. Suresh, for this excellent presentation. I want to ask about the technique and the position and the anesthesia in your operations. And as I understood, you use only uniport,
Biportal.
biportal endoscopic procedure, not monoportal.
Not yes. I was initially I got my training in monoportal endoscopy, but later on, for my practice also, I shifted to during my training procedure only. I shifted to biportal endoscopy, and I since then I'm performing biportal endoscopy only.
So, do you use general anesthesia or do you use
Yeah.
epidural or?
Yeah, for biportal endoscopy, I always, almost always use general anesthesia, but there is a possibility of epidural anesthesia also being used, especially if the patients we cannot intubate the patient or there is some issue with chest or in such scenarios, epidural anesthesia can also be used. Uh, your anesthesia team must be familiar with epidural anesthesia because along with epidural anesthesia you might need some sort of sedation, and a lot of anesthesiologists they are not trained with long prolonged surgeries being performed in epidural anesthesia, especially the patient being in the prone position.
Thank you. We met with Dr. Suresh in Mumbai during the World Congress of Spine Endoscopy, and we talk with him with Efecan Erişken, and Efecan Erişken impressed from Dr. Suresh, and he bought many tools from Mumbai and bring with him, but he didn't start yet, and probably next week he will start with his first case. Maybe he want to say something, and maybe he want to ask something.
Yeah. Hello, sir. We met in India,
Yes, I remember.
and I want to thank you about encouraging me to start UB surgery, and thank you for your support. And I want to ask some question about as a beginner for as a initial cases uh, which kind of scope should we prefer, 0 degree or 30 degree?
So if you are not familiar in the initial case, you can try with a 0 degree scope. 0 degree scope is relatively easier to understand, but what I suggest is though 30-degree scope is a little bit difficult, you push yourself for 30-degree scope because ultimately using a 30-degree scope and developing your orientation, visual orientation with 30-degree scope is important because it has got a larger angle of view, and operating on the opposite side, achieving a wider decompression is easier with 30-degree scope.
Okay. Should we prefer uh, uh, pump in irrigation, or should we prefer gravity?
Gravity. Till now, I was in India. What we saw or how we were trained was using a pump system. But in my center, I don't have a pump, and I always operate with a gravity assisted thing, and I haven't have any problem. So if you have a pump, you can use it. You can set the pressure to 40 millimeter of mercury, and you can increase it up to 60 or 80 millimeter of mercury intermittently if you need some hemostasis. Otherwise, if you don't have a pump, you can start with gravity assisted only also. So
Okay.
it's not a problem.
Okay. Thank you. We are planning to start this week the UB surgery. As I promised, I will share with you
Definitely,
my first
definitely.
case.
You post your case, share your images with me, and however can I can help, I'll help, and you can take me in my. Um, you can connect me with WhatsApp or Viber or Zoom,
Yeah.
and intraoperatively also. And for the positioning, your markings or initial port positions, placement of your ports, triangulation.
Yeah.
I'll be there and I'll help you. It's not a problem, and I'm very happy that you are going to start unilateral
Thank you. Thank you, sir. Thank you.
Anybody has questions or comments? Sir, I would like to ask one more question, if you don't mind. When we talk about redo surgery, if surgery previously initially has been done by endoscopic, so for some reason patient is coming second time and you decide to do the second surgery, will you go again for endoscopic or for open? So how for young neurosurgeons to have this understanding regarding the redo procedure?
So basically, what I feel is it depends on your confidence level. So and your experience. So once you are familiar with the anatomy, you recognize the tissue in the with an endoscope, because seeing is with your own eyes is different than seeing under the microscope. So however, with microscope we develop the orientation pretty quickly, and with endoscope we might get disoriented because of the proximity of our camera to the pathology itself. So sometimes it might take you a little bit time to get oriented. So once after you get oriented, I don't think there is any redo case that you can't do with endoscopic operations. It depends on your expertise, your level of orientation with your tissue, and how much clearly you can dissect the tissue itself. So uh, I don't think it's a problem. It's a contraindication, but yeah, you select your cases in the beginning judiciously, operate on fresh naive cases, and gradually progress on to uh, redo or reoperations.
Thank you, sir. If nobody has questions or comments, we can finish our session. And I would like to thank you again, sir, for your time, for your experience, tips and tricks. For all of us, it's important because the modern world is rapidly switching to endoscopic techniques. I'm not talking only about neurosurgery, cranial or spinal, I'm talking about general surgery and gynecology. So we should have a clear idea about what is endoscopic surgery, how to go, selecting the patients, age, supporting young neurosurgeons, and understand possible complications. So, oh, somebody has questions. Okay, let's see. Yes, Dr. Avanish wants to ask the question. We will wait.
Okay,
Sir, I'm from India. I am a practicing neurosurgeon for last 13 years. I am also planning to start my UB this month. I just attended a course also. I have a question regarding the fluid, what you said. So in normal circumstances, what size of bottle and what uh, size of the bottle we should put for the irrigation if we don't have a pump to maintain that pressure, and how to see that we maintain a pressure of around 40 to 60 mm of Hg? How to assess that? Is there any clinical way, or we just have to see that the fluid is flowing in a nice manner? Is there a way to check the pressure, or at what height should we set the bottle? Any suggestions?
Yes, thank you, doctor. So it's a very relevant question. So if you have a pump, it's not a problem because the pump has itself setting over there, so you can use it automatically. But if you don't have a pump and you want to perform your surgeries under gravity, there is the pump. You usually it's put above just above one. Raise your hand and put the uh, bottles or the irrigation system above one hand height above your head. So that gives you a rough idea of the positioning. And if the water pressure, it's almost always equivalent to the height of water bottles that you can measure from the incision side or the operative side. From the operative side, if you want like 60-70 millimeter mercury pressure, so if you put the water pressure at like 70 centimeter of water, it will be the similar pressure. So roughly you can calculate in that sense.
And sir, I have one more question. What is the fluid of choice? You always use normal saline or any other thing
Yeah,
also, ringer lactate?
normal saline is the fluid of choice
Uh,
because the coagulation and these modes, it needs sodium ions that need to transmit the electricity between two electrical probes that the instrument are used. So normal saline is the fluid of choice.
okay. One more question. Is there a difference between a RF ablation and plasma ablation? Because some of the companies, they are promoting this plasma ablation in India. So right now I am very
Uh,
confused that should I go?
these
Is
days,
there any difference?
Exactly. These days, most of the machines they provide probes that function with plasma. The plasma is a coablation mode. So coablation means it evaporates the tissue not by heat or electrical heat generation. It does it by dissociation of hydrogen ions. So there is not much of temperature rise even with the prolonged use of coablation mode. So most of the equipments they will be providing with coablation mode, and the probe will be equipped with coablation mode. There are a lot of Indian companies that have developed these machines, and these are cheaper than Korean or Chinese counterparts that we have right now. So I know of one of my centers I use Indian Jayan companies.
Yeah, yeah,
Yes.
yeah. Similar,
Yeah,
sir.
yeah. It's like one third the cost of Bond's radio frequency machine.
Okay, sir. Thank you, sir. Thank you.
Maybe I can add some information about the water supply. We are using a pressure cuffs, and it's like a tension pressure cuffs, and just larger. And we use 3 liters bags of saline, and we put the saline bag, 3 liter saline bag, inside of this pressure cup, and then we arrange the pressure to the level as we want. Generally 30 mmHg. This pressure cups is cheap, not expensive. You can buy it easily. Okay, that's all.
Thank you.
So
So
we finished, I think, all the
yes,
questions and comments.
finish our session. Some
So
final comment from you, Dr. Hassan. Hocam.
I want to thank Dr. Suresh one more time. And I want to thank everyone who joined us this evening, today, here. And I hope to see Dr. Suresh again one more time in Turkey, maybe in Nepal. And see you. Thank you so much.
Thank you so much. Yes, see you.
Bye bye.